I think we've already heard from Jay, and we've heard about functional testing. We've heard from Dr. Fuster about what's new in the world of carotid and vascular imaging with echocardiography. Dan has graciously conceded his role on the panel to open it up for a bigger discussion of the new guidelines, I think, and how they're going to affect the prevention in this country. And just a few comments of mine, say 2 minutes. What I took from Dr. Fine's message is that it is extremely likely that there will never be an RCT to evaluate the role of coronary calcium to show that it improves outcomes, nor will there be a trial to show that carotid ultrasound, whether 2D, 3D, or 4D, affects outcomes. So to prove imaging...
With 500,000, let's say...
With $500,000, okay. So to prove that imaging has outcome value is simply not going to happen. And now we have the new guidelines, which, from my perspective, are really a marked regression. The role of imaging has been vastly downgraded. At least in the past, coronary calcium was reasonable for the intermediate group, and now all you have to do is have a risk score of greater than 7.5%. Most of them will be in the intermediate group, and you don't need to do anything else. There's no need to modify it by doing a coronary calcium or an echocardiogram. There is no mention of any form of ultrasound in the new guidelines. And Khurram Nasir, Khurram, are you still here? Shared with us that he's already done an analysis of the MESA data looking at the new guidelines, and you only would have to scan 1 out of 2 patients in the intermediate risk to find somebody who did not need to be on therapy by outcome data. And you also would have only need to scan 2 patients to find one who needed to be on therapy, who wasn't covered by the guidelines. So it seems to me that instead of de-emphasizing risk factors, which is what SHAPE has been all about, as the primary tool for establishing risk, using atherosclerosis imaging as the primary tool rather than risk factors, we have done an about-face, and we're going back towards the dark ages. So I'd like to throw this open for discussion, and we have a lot of people in this room who've been very instrumental in contributing to our body of knowledge in terms of atherosclerosis imaging and prevention, and I'd like to call on some of them specifically to offer us their insights. And the first one I'd like to ask is Erling Falk.
Erling, come here, and if you don't mind, bring up the entire panel here.
Okay, so I'd like to ask Erling and Raymond Erbel and Dan Berman to come up here, and Dr. Koenig, are you still here?
Yep.
Yes,
perhaps you can talk to us about biomarkers, and Tasneem.
Yes, Tasneem.
And Jay, I don't want to exclude you. You said your piece already, but I'm sure you'd have more to say. So, and if I've left it, and Robert.
Yeah. So
Robert Sapirko, who can also talk to us about cholesterol.
Please come. So the plan is you'll have 2 minutes and aiming at the camera, making your case. Basically, your conclusion of what the guideline was, and the downside, the upside, some upside. So the full part of the glass, and then what do you recommend the next should be? Dan, you start.
I think I'd rather if go a
Erling?
little bit later.
Okay.
Erling, could
Erling,
you start?
please go ahead. You get the first gets burned.
Well, I was not prepared for this, but I wrote something down here this afternoon when I went through the guidelines. Just to see how they could be improved, because as I understand the guideline, in fact, now they lower the threshold for the indication for giving statin. And in fact, what is determined for whether you will have statin, a strong determinant is age alone. When you reach a certain age, you have a high risk, or at least a risk that is an indication for statin treatment now. So it will, as I see it, it will result in over-treatment of the elderly. So you could say to prevent over-treatment of the elderly, you could do a kind of imaging to find the elderly who don't need lifelong treatment. And it is in fact, you could try to do imaging to find, for example, those that has a 0 calcium score, or those that have no plaque in the carotid artery. There's no reason to treat an elderly person lifelong with statin if there's no sign of disease. So it was one thing. In the elderly, you could try to avoid over-treatment of the elderly. at the other end. In fact, to get statin now, you need to have a certain age. Very few people below 60 years of age or 55 years of age will have that risk that will give them the statin treatment. So I think you have a problem now to prevent, or we always have a problem to prevent early disease, premature event, and to catch that patient, we could do imaging in the younger population, do imaging in the younger population to find those who need treatment, because you don't find them with the guideline we have today. So you could avoid over-treatment of the elderly, and you could avoid under-treatment in the younger people. Then I think there is also a problem with the guideline, in fact, that they only focus on non-Hispanic white people and African black people. And in US you have a multi-ethnic society. And in fact you have 20% here that are not covered by these guidelines. You have the Hispanic, you have the Asian people here, Asian American, you have the Native American. And I heard here before, I think there is a eightfold different in risk in the population here in US from different geographic region or ethnic group. And in fact, if you want to treat all of them correctly, you need 8 different scores, because you cannot use the same risk score for so diverse a population. So I think what I also miss in this guideline, it is that you don't recognize or you oversee many minority group here, and in fact big minority group here, just by providing guidelines for white people and African American. And then the last thing I will mention, it is, I think we have also in this email going to and fro, they have some mentioned residual risk. I think you mentioned residual risk. When we will have new drugs, they will be expensive. We hope they will come, the new drug. We need to find the people that go into trial to do something about the residual risk. And to find these people, we probably also need imaging to find high-risk people to do something about residual
More
risk.
intensive treatment.
Yeah. So I think it's
Thank you.
fourth situation we could.
Yeah.
We will have more discussion of these guidelines, but I would just like to go back to something that Dr. Fuster brought up, and that is both adherence and compliance. Even with the new guidelines, we would have to get patients to be taking their medications. And I don't think there's enough emphasis on lifestyle modifications of diet and low saturated fat diet and exercise. But how do we motivate patients? I think in our Eisner trial, which was not patients, these were people on the street who were randomized to either getting a scan or not getting a scan. The people who got calcium scans were shown the results of their scans. We had 2,000 patients in the trial. And despite the fact that these patients got anonymized reports, that they were only talked to in one brief episode by a nurse practitioner and then shown their scans, we had a significant reduction in the Framingham risk score in the patients who were scanned, compared to an increase in the Framingham risk score over a 4-year period of time in patients who weren't scanned. We had a lowering of systolic blood pressure, and in patients who were overweight, we had a reduction in weight. All of this done without increase in the overall costs, because of increased costs in the patients who had a high calcium score were balanced by decreased costs in the patients with 0 calcium scores. So I think we have to recognize that there still is a gap between our prescription of medications and what could ultimately happen with the patients. We have to motivate them to change their lifestyle. We have to get them to adhere to the recommendations of their physicians. And that through these various imaging techniques, the opportunity from objective demonstration of what they have in their arteries, that the disease is present rather than just risk of disease being present, can be an effective tool without great expense in changing, ultimately, outcomes.
Raymond, for those of you who may not know, Dr. Erbel is the architect of the Heinz-Nixdorf recall study.
Thank you for being involved in this discussion. Well, of course, one needs time to fully understand these new guidelines and what they imply to tell us. We have to agree what we have heard from Don and also from Alan Falk. My motivation is the sudden, unexpected death of people. And as we have heard, we have not really good reduction of deaths in the people 45 to 54 years. And that is a group of people who are in daily active life. And each of these myocardial infarctions that occur suddenly is a mistake or disaster, failure of preventive medicine. And therefore, I do not like to know in our town, 600,000 people, there are 1,200 to 1,300 sudden deaths each year, which are unknown. And 60% of the people die before they reach a hospital, before they are recognized as patients. And I think that still the major emphasis should be to look to atherosclerosis, to see who has disease and who has not. And when I look to the data from Valentin Fuster, I was happy to see that he also shows in these curves that more than 400 calcium score has the highest risk, what many already have shown. And that is what we have to take into account. It's not only, and that means also education of physicians, somebody have risk and no risk, but it's how we deal with this information in guiding the patient. It's very different if I see somebody who has 80 calcium scoring or somebody who has, at the age of 45 or 54, 1,500. That's not rare. But these people have to be informed very differently, very, very differently, yeah, to avoid this exertional exercise, to avoid to go to countries where nobody can help them, yeah, to avoid to do mountain biking, to avoid marathon, but do sports, but not this unhealthy form of sports. So I think the guidelines and to emphasize only to look to risk factors is for me a disaster, because risk factors are not the driving force of death. Plaque burden counts, and nothing else than plaque burden. Whether you look or not, you're looking to hypertension, if you look to high lipids, if you look to diabetes, plaque burden counts, and plaque burden brings it to risk. And I want to tell my patients, and I think what Don says with the Eisner study, that is motivating. Yeah, when you show at which percentile distribution he is in comparison to others. And thereby, of course, a lot of questions come. But we have to take the time then, in special settings, to discuss it and to guide the people through their active life. Yeah.
Before I ask Tasneem to comment, I'd like to congratulate Larry and NHLBI for dissociating themselves from the new guidelines. In the past, NHLBI issued the guidelines, and the decision was made to no longer do that. Good decision. Tasneem?
So, as Dr. Fuster said, sometimes the guidelines have got no connection with the prior guidelines, and that's unfortunately the case with the new ones. So as you know, both calcium scanning and IMT assessment were class 2A in the prior guidelines, and now coronary calcium is class 3. And 2B, and IMT is class 3, which means it shouldn't be done. So we have really, and really the difference between the two studies, there is no new data that has come out that would make such a drastic change in recommendation. I think the new guidelines still underserve women and young population. That is the biggest issue I have with these guidelines, not having, obviously also that we will be over-treating a lot of elderly men or older men above 60 who happen to be just high intermediate risk simply because they're men. Let me give you a very simple example, and I really think this example, I'm trying to follow the guidelines. I had 2 patients in my clinic yesterday. So there is a 52-year-old woman who comes to my office. She takes care of herself. She has a list of at least 10 supplements she takes. You know, she takes omega-3, she takes fish oil, she takes wine extract, she takes everything that's good and healthy. She has an LDL cholesterol of 120. She's normotensive. She's not a diabetic. She exercises. She's normal weight. She's not depressed. She has a family history of premature coronary artery disease. Her father had bypass at age 58. Her physician had already done a stress echo, and you know what that result was. It was normal. So I looked at the guidelines. I punched her risk factors into this new equation that has come out with the new guidelines, which also takes into consideration the stroke score. Guess what her score was? 3.8. Okay, so I decided to do an IMT on her because we offer this service clinically, and her IMT throughout her segments was more than 75th centile. So I sat down with this patient and I showed her her IMT images, and she says, you know, Dr. Naqvi, I have tried everything. I had liposuction, I've lost weight, I do diet, I do exercise, I take all these supplements, but I said, look, your vessel looks like this, despite all this. So she's now on, today she's on 10 of Crestor, but she will increase it to 20 of Crestor. The guidelines, this is not guideline based. According to the guidelines, I should probably have sent her maybe to, you know, reassured her, or at best do an ankle brachial index or CRP, or a coronary calcium scanning, which, you know, I didn't want to do in a 52-year-old woman because, you know, it may be normal. It may not be. I had another 67-year-old male, very healthy, prostate cancer, comes to me for calcification that was found on his CT scan, which he had done for his prostate metastases. And the report said calcification draping the coronaries. And this man did not want to take statins because his hematologist had told him that statins interfere with prostate cancer. So this is another patient I did an IMT on, and this is the worst IMT I've seen amongst probably the top 5 worst IMTs I've ever seen. This patient is going on statins. And we looked at Google and we didn't find any data. I sat down with both of those patients, showed the patient their images, and it means a world to these patients. You know, they are both going to stick with their lipid-lowering therapy. It is such a simple technique. We have a paper coming out showing that you can teach it to residents who become as good as an expert in finding abnormality in great majority of patients. The companies are trying to make technology simpler and easier to use by common people in doctors' offices and so on. So on the one hand, we had this effort happening, and on the other hand, we have this new guideline, which I think is going to be a big blow to a great majority of our younger population, unfortunately, who won't derive benefit.
Thank you. Wolfgang, would you care to comment on the guidelines from the perspective of biomarkers?
Yeah. Well, thank you very much, Harvey. First, I'd like to echo what Rainer Abel said. I mean, I had briefly the chance to look at the new guidelines, and I must say I was terribly disappointed if this was the work of 4 years, and I think we have been waiting for about
2001.
2001. Gosh, even longer. And I have not yet digested what I have read. I have so many difficulties in understanding quite a number of decisions and arguments they put forward. In terms of biomarkers, as you may recall in this document, in terms of blood biomarkers, I think it was only the CRP that has been suggested to be used in those at intermediate risk. So there was not really a change compared to the ACCF guidelines that were put forward in 2009. Now we all know that blood biomarkers do have severe limitations in terms of improving risk prediction, and we have tested so many of them. I think the major problem is that what we measure in the circulation does not necessarily reflect what's going on in the plaque. So if you measure MMPs, for example, in the circulation, that probably means something quite different than MMPs in the plaque themselves. So I'm a little bit skeptical for the future with regard to biomarkers or blood biomarkers. Also, in Europe, we, under the guidance of Stefan Blankenberg, we have set up a European Union project. It's called BiomarCare, where we study on a European basis biomarkers, blood biomarkers, conventional biomarkers. We're looking into into transcriptomics, into microRNAs, into biomarkers that have been selected from plaque, for example, and try to evaluate in a standardized manner panels of biomarkers in 150,000 subjects, and try to harmonize those data. So maybe in the future we'll come up with some more precise data regarding the specific panels of biomarkers. Maybe we also gain some new candidates from omics technology. Also, we have been already for some time in that business, and there's, to my knowledge, not really a breakthrough recognizable. So we will see what the future brings. But in terms of the biomarkers, I think in blood biomarkers at the moment there are certain limitations.
I'd like to make a comment before introducing Robert. You know, HDL has taken a big hit lately, of course, with the AIM high, and people weren't so upset because the thought was, well, it doesn't really matter as long as you get your LDL low enough, then the HDL doesn't really matter. But now, as of November 12th, lower was better. From November 13th on, lower is no longer better. So vast change. All the emphasis on lowering cholesterol as much as you can is no longer an issue. It's no longer the point of treatment. So Robert, what does this do for the whole issue of treating HDL? What does it do for advanced lipid testing? What does it do for niacin and fibrates?
Well, thanks, Harvey. And I had a chance to pore over this on the flight out. So let me start in defense of the expert committee. They're all well-established people with good reputations, and so you can't attack the people. You can address some of the things they said. And in the text, they say this was not designed to be guidelines for management of atherosclerosis. So it should not be viewed as a management system as previous guidelines were. But they have a very strict constructionist approach. And if you read it carefully, what they were asking when they said there's no evidence for this, what there's no evidence for are randomized clinical trials that initially titrated to specific LDL cholesterol levels, and therefore you could see a difference in lower being better. So let me say that again. Trials designed from the ground up to titrate to specific LDL levels. So if you remember TNT, that was 10 and 80 of atorvastatin, and the LDLs were about 70 versus 100, but they didn't titrate to those levels. They just gave them a fixed dose. So in the text it says that these were all fixed dose studies, which is absolutely true. So what they're saying is absolutely true, but it ignores the reality of the world. And I think that's the problem, is they took a very narrow, strict constructionist approach, and if you pay attention to that, they're absolutely right, but that doesn't impact how I think 99% of physicians treat healthcare and treat their patients. A couple other quick things is they ignore this relative risk, absolute risk thing. So the 25% relative risk reduction with statins is actually a 3% absolute. And in something like, what was it? The lipid study, I think, they had 650 events in the control group and 550 events in the treated group. So we're still going to see a hell of a lot of patients coming in with acute coronary events on statins. So simply giving somebody a statin, it does not prevent events, and this has been foisted on the American public. You get a sense because some famous guy that invented an artificial heart has an ad on TV saying, you know, take my statin, but most people still have events. So that it ignores that entire thing, which is important to us clinically. It ignores pathophysiology, which is the basis, I think, that most of us learn medicine on. And so this is an epidemiologic statistical approach for a public health policy as opposed to individual patient management and treatment. And the last thing I'll say is the worst thing, I think, is that insurance companies are going to use this. So insurance companies are always looking for justification not to pay for anything, and they're going to say, great, you know, we don't have to pay for anything now. So those are my comments.
Could you comment on HDL?
Oh, sure. Well, the HDL, in my opinion, is not dead. There's plenty of data to support the importance of low HDL and cardiovascular risk. There's evidence to support raising HDL with nicotinic acid, going back to Dave Blankenhorn, if people remember him from Los Angeles, to all of Greg Brown's studies. The more recent studies The AIM High had a problem with the control group raising their HDL, number one. And number two, they used a niacin dose that was low, 1,500 milligrams a day. In all the older studies, our Scripps study, Dave Blankenhorn study, we use 3,000 to 4,000 to 5,000 milligrams of niacin. So it's a dose issue. And in the HPS Thrive 2, 50% of those people were in China. And so there's a huge difference in the type of people in those trials. And there's major issues with compliance with nicotinic acid. And I didn't see any evidence of strong compliance control. So, you know, I could at some other point talk to you about it, but I think there's some really major problems, and I would not give up on the HDL story yet.
Jay?
Well, I think it's apparent that the guidelines were written by a committee, and this committee couldn't agree. So that on the one hand, they have scrapped thresholds, which we all knew were incorrect, and scratch target responses, which have not been demonstrated, as was pointed out, to be effective, and probably don't matter because the benefit of statins is exactly the same if you begin with a high LDL or with a low LDL. The benefit is comparable. So using that data, they managed to abolish the threshold concept and abolish the targets, but left intact, and made even worse probably, the identification of individuals who need therapy, because they no longer have a threshold for therapy. So they've resorted to risk assessment, which goes back to using the same thresholds that they have discarded in the therapy arm. So this committee has gone partway and recognized the inadequacy of using numbers. And as Val had pointed out, we're advocating abolishing the numbers for blood pressure too. Val said something about how can you treat a patient with an antihypertensive drug who has a normal blood pressure. We do that all the time because they have early disease. And these drugs don't aim at blood pressure, they aim at vascular health. So yes, you do treat people with a normal blood pressure, and you do treat people with a normal cholesterol if in fact they have early disease. And that brings us to the question, how best to identify early disease? If we wait until people have extensive plaque burden, and I fully agree that plaque burden is a risk for a near-term cardiovascular morbid event. But if we wait until plaque burden is there and intervene, the likelihood is we will delay events but not eliminate events, and the cost to healthcare and the cost to society will not go down, it's going to go up. If we begin early and identify those individuals who are going to develop plaques and intervene effectively at an early stage, we eliminate them ever having plaque burden and ever having morbid events. Now, can we do this with carotid IMT? No, not by itself. I appreciate that carotid IMT is valuable, and we do carotid IMT on every patient who we screen. But we do that among 10 tests, studying the health of the arteries and the heart. And those 10 tests provide us a score, which tells us who is at risk and who is not at risk. And that allows the opportunity to really intervene on those at risk. So it's a far more comprehensive approach to screening, but in fact is the SHAPE concept that is the disease we're interested in, not the risk factors.
Right. So I'd just like to have one more speaker. And Larry, I realize you are not speaking on behalf of the guidelines. You're in a different arm entirely, but you've heard a lot of comments, most of them pretty critical. I'm wondering if you could come up here and tell us your feelings about these comments and what you think should be done going forth to resolve some of the issues that were just raised.
One thing I would say is that the ACC and the AHA, taking over the guidelines happened, probably this summer. So, these guidelines are a product of the previous process and some input from ACC and AHA. And I wonder whether the next set of guidelines might be somewhat different, because I think they might have more ACC and AHA and other organization input. So I think one thing you have to understand is sort of the process that led to these guidelines. I think you've raised a lot of interesting, questions. I think guidelines, what I've learned through my involvement, this is my own personal opinion, is that guidelines are a combination always of science and policy or value choices. And that's what makes them so difficult. Because, and different people give, in the spectrum of how certain you have to be about a decision and how you want to interpret how much of the data you're willing to look at. So these set of guidelines are done at a time in our sort of science where the sort of U.S. preventive task force philosophy is the dominant philosophy. And, that's very much based on, focusing pretty much, I mean, the risk assessment guidelines here obviously are different because they're not really about trials. But the dominance of clinical trials that are either rated as fair or good, is really dominant. And the other issue, one that you've pointed out, is a lot of the trials we have, of course, were done 30, 20, and 10 years ago. And I think one of the challenges we have, which would get to the last part of the talk, is I'm hoping that some of these disruptive technologies will in fact succeed, at least in part, because our most fundamental problem, one of our fundamental problems, is we have to generate contemporary data to make these decisions. And right now, our ability to do that it's not just money. It's just so limited. A trial takes a decade. A big trial takes a decade to do. As long as that remains the situation, we're always sort of going to be, looking in the rearview mirror. But you would hope that with modern technology that we can get to the point where we can answer, these questions more quickly. And the other point I would make is that I think there's a change in focus in epidemiology, or there's a potential for a change. So previously, Framingham and Mason, all of those kinds of studies, which obviously revolutionized how we treat how we prevent cardiovascular, disease, not perfectly, but obviously had a huge impact. We're now in a situation where we can focus much more of our our epidemiological resources on clinical questions. Framingham with 5,000 people is not a very big study if you want to study young women who are going to who have MIs or sudden death, because the number of sudden death of people under 60 is just too tiny. And you're also looking at people who had sudden death over the last 30 years. And obviously the world is very different today than it was in 1980. So anyway, so I made my point, as I think technology hopefully will help us close the gap.
I think I'm going to get that tagline from there: technology and personalized medicine. Really, this guideline was a giant leap backward to not having personalized medicine. And the direction should be towards individualized decision-making and personalized medicine and using technology. I take the liberty of criticizing them. I went to School of Public Health and medical school. I know what the mindset is in a School of Public Health and epidemiology and population-based approach. But we're hoping that the AHA-ACC guideline will invite these real hands-on researchers, clinicians who treat patients, save lives, as well as hypothesize and write papers, bring to the writing committee. We got two quick things before we leave. One question, the end of the...
Yeah, it's actually a comment, okay?
Please.
Something that bothered me, besides all of the issues that have already been raised about the new guidelines, is that what we're basically doing is we're pushing towards high-intensity statin therapy. What nobody in the guidelines addressed, other than very peripherally, is the fact that if you look at real-world data on statins, there's adverse events associated with statins that are dose-related, that those dose-related adverse events are predominantly, in my mind, two categories. One are mitochondrial dysfunction related, which you can almost go ahead and put the myalgias, any fatigue, cognitive, as well as LFTs, all within a category of mitochondrial dysfunction, because that's where the mitochondria, those are the four organs, brain, heart, skeletal muscle, and liver, that have the highest density of mitochondria and highest mitochondrial content. In addition to that, if you look at the studies that have been published over the years, and if you look at the effect of statins on the production of arachidonic acid, there's 15 to 20% increase in arachidonic acid production and release in conjunction with statin therapy, especially the data have been done with 20 and 40 of Symbo. But the important thing is that that takes you down a eicosanoid pathway for leukotriene B4 and for thromboxane A2 that are not a favorable place to be. And yet, perhaps some of the residual risk is in fact a reflection of the fact that we're doing good things with LDL-C and the initiation of the atherothrombotic process, but on the other hand, we're doing bad things by some of the off-target effects of statins.
Thank you. Thank you. I'm going to summarize quickly. You said that so the importance of some of the limitation of this guideline is the overtreatment. Of course, Erling mentioned that, and the potential compliance and potential adverse effects. And to their defense, statin is the safest drugs comparing to all other things that are out there. But your point is well taken that we don't know. It might have had some contribution to the residual effect. Vulnerable plaque is not just plaque, it's vulnerable blood and other things that are cascade of leukotriene and prostacyclin and versus thromboxane pathway and so on. So this is for the online audience that couldn't hear you. And you know, Kuram and folks at Roger Blumenthal group published a very series of publication emphasizing on de-risking and preventing unnecessary treatment. I think it's really important for the public, general population, if you can verbalize it in 1 minute, that bottom line message.
No, I completely agree with your message. Is patient preference is another issue that we do not take in this whole discussion, the stakeholder, the most important. And what we are saying is asking them to be on a statin, not for 6 months or a year, maybe lifelong, 20, 30 years, and the cost of the labs, bringing them back, side effects. And if you ask them and give them the option, if a test or atherosclerosis can detect that they are at a very low risk and involve them in shared decision making, A, whether they want to be on it or not, B, even if they want to be, can we have flexible goals? This is what atherosclerosis screening really helps. And I think the philosophy of the current guidelines go hand in hand with the original shape. They say treat risk. However, they're only a little on the sideline how accurately to identify risk, because there is huge heterogeneity. You can have high risk but actually be at low risk and vice versa, and that's what everyone here has elucidated. I think so it's time to go back to the original shape guidelines, subclinical atherosclerosis screening first and then treating the risk factors.
All right, thank you. So before we end today, we're on 4. We need to leave this room in 2-3 minutes. I want to have one quick announcement. Before we make an announcement, we want to take another picture like this. So please go ahead and come right here, right in front. This was November 13, 2006. It's 7 years later. And I think we just took one step. And that's the acceptance of disease and risk, not the risk factors. So please come here. Jeff from SHAPE has a quick announcement for you guys and for folks online. Jeff has taken our job, come on in, Jeff, all of these scientific talks, all of these general academic lectures to the real world guys, those guys who are treating patients, community hospitals, and some network of healthcare systems, trying to teach them shape and how to go out. Now, obviously, with the Obamacare, they have more incentive to learn because of these limitations. So, Jeff, please tell them 1-2 minutes, what is the advantage of SHAPE Centers of Excellence?
Sure. The SHAPE accreditation program, as Mort said, is kind of a clinical, guideline-based and research-based approach to really going out and educating your primary care community to send the appropriate patients for these screening tests, coronary calcium scoring, carotid IMT, plaque assessment, et cetera. What we found from going out and hitting the streets is that the primary care community is largely unaware. They're very confused by the tests, number one. Number two, who are the appropriate patients to send for the tests? And maybe most of all, what do we do with the patients once Mrs. Smith comes back to the office and has a calcium score of 81? What do I do with her? So as a result, they shut down and they quite honestly don't order the tests. And that's what I found with both of the cardiology practices that I was with. As soon as we went out and put together an educational program to bridge that knowledge gap, quite quickly the referrals started coming in and allowed the primary care community, including OBGYN, to better serve their patients. So I think we're on our third year now of accrediting hospitals and practices as SHAPE accredited centers of excellence, which is much more than an accreditation. It's also a very complex primary and secondary prevention program, a turnkey program, training. And then what we found, quite honestly, is our results are fantastic. The average direct-to-consumer hospital that's doing screening is averaging about 1 patient per day. Our SHAPE centers of excellence are averaging over 8 patients a day once we get out and educate the referring community on how to select the right patients, build that into their prevention paradigm like they think of mammography or prostate screening. Quite quickly the effect snowballs, and of course we're capturing a lot of disease. Financially, the return on investment is just phenomenal for the sites that choose to become accredited, and they're sending the right patients, they're finding disease, and they're making money at the end of the day doing accurate and appropriate prevention. So again, I'll be in the SHAPE booth throughout the conference and have handouts. If anyone's interested, we'd love to bring the program or get some information to you so you can take it back to your sites.
Great. Thank you, Jeff. Round of applause for everybody. This was a great event. As I said, about 15,000 people watched this and get their message. We try to convey a message that innovative thinking, going beyond the ordinary, is what SHAPE is about. We're not about atherosclerosis imaging. We're not about a group of doctors who are promoting their agenda. We're not talking about genetic or whatever. All of us have our own interests. Jay's been for years promoting his. But we have one common goal, and that is push the status quo beyond the status quo to go for advancement. Please take this message, and the group, please stay here for a quick message. We need to leave this room in about 5 minutes, so that would be the end of today's meeting. Thanks, everybody.